So we'll go ahead and get started with the next session. I will be presenting about stem cell transplantation. It's a privilege to be able to do stem cell transplantation. It's a great combination of many of the things that you've gone through, combination of dealing with oncology and hematology and immunology. It was really nice to hear such a great immunology presentation by Dr. Pai, and she also gave a lot of my content, so I'm grateful for that. Let me start you out with a question, and this is definitely part of the content. HLA and donor issues are very important, and we'll be talking about those in great detail after this question, but let me first pose a question to you. You have an 18-month-old child with ALL who's in second remission and is referred for transplantation. What would be the best donor for this child? The child's own sorted cord blood, because that child's stored. A 55-year-old female unrelated donor who's a 7 of 8 match. A cord blood unit matched at 4 to 6 antigens that has a cell dose of greater than 5 times 10 to the 6th per kilo. And actually that's a mistake there. It should be 10 to the 7th per kilo. A 40-year-old male unrelated donor matched at 8 of 8 loci that's only willing to donate peripheral blood stem cells, or a cord blood unit that's matched at 6 of 6 antigens and has a cell dose of 4 times 10 to the 6th per kilo. And again, that's a mistake. It should be 10 to the 7th per kilo. So the correct answer here, for a number of reasons, is E. Just to go through this very quickly, and I will cover these issues more specifically, you'd never give a child an autologous transplant for ALL. Allogeneic transplants are the best transplants for this particular disease. An older female can lead to increased risks of graft versus host disease when the female has had children. And a 7 of 8 match is not ideal when you have better things that you can donate. A cord blood that is matched at 4 to 6 antigens is not as good as a cord blood that is more fully matched. In pediatrics, peripheral blood stem cells lead to a significant amount of graft versus host disease that's been shown in studies to be inferior to bone marrow. So this is why E is the better answer. Let's talk a little bit about HLA. Important content that you need to know is how HLA is inherited. HLA, of course, the HLA complex is located on chromosome 6, and this particular diagram shows how the genes are aligned. And one important thing for you that won't necessarily be content is the distance between A and DR means that there will be a crossover rate of about 1 in 100, meaning that a sibling that should have been matched had a crossover and could be almost a complete match, but a mismatch in that area. As you can see, what occurs with this is it's inherited in what seems like an autosomal recessive fashion, where you get one gene from mom, one gene from dad, and therefore any given brother or sister has a 1 in 4 chance of being a complete match, with that caveat of having a crossover in 1 in 100 patients. There are a number of alleles for each of these genes. Every time I update this particular slide, it's out of date within a month because new alleles are being found all the time. I think the important thing to understand is that class 1 HLA alleles, A, B, and C, there are a lot of them. Class 2s, B1 is extremely important. DQB1 is now really looked at very closely, as we'll talk about further. Many programs are screening for DPB1 at this time, and some are even looking at what are called DRB345, and we'll go into more detail about that. But the key thing to remember about HLA is that there's incredible genetic diversity in this. Therefore, finding a donor in the unrelated setting is very difficult, and you need to see very, very large numbers in order to find this. And the only thing that saves this is that some HLA combinations are very common and continue in the population. The other thing that you're supposed to know for content is things that lead to graft versus host disease, and know and understand that minor HLA antigens can be associated with graft versus host disease, but they're also very important because they're associated with the graft versus leukemia effect. Please do not try to memorize any of the material on this slide. Because this hasn't necessarily been, again, this is out of date the minute I put it on a slide. There are a number of minor antigens that are being described. Some individuals are actually trying to use those minor antigens in order to do targeted immunological therapy. The key thing to recall about minor antigens is that even if you have a complete HLA match with your bone marrow transplant, you have a risk of graft versus host disease. That graft versus host disease is likely due to minor antigens. In addition to that, when you have a complete HLA match and don't get graft versus host disease, you still can have a graft versus leukemia effect or a graft versus tumor effect, and that graft versus tumor effect that can decrease risks of relapse can occur by immunologic reactions against minor antigens. So minor antigens are important from those two aspects. This is a nice slide to really kind of, to help you understand what people are doing nowadays in order to type different types of donors. So for a matched sibling transplant, whether you're doing bone marrow or peripheral blood stem cells, many labs actually, I say allele level here, and just to remind you, allele level is DNA-based typing, and antigen level is an older method where we're looking essentially at the protein with a serological type test. Antigen testing is still done by some labs. It's a very quick turnaround, and in some cases it's inexpensive. Many programs now are just doing all allele level testing, but essentially to define that someone who is a true sibling is a match, you don't have to be as specific. Some groups do very minimal testing for this. The majority of programs, however, do full typing of all A, B, and DRB1 plus C, although some people just do A, B, and DRB1 in order to make sure that their matched sibling is a match. And you remember what they're trying to do is find A on one end of the gene and DRB1 on the other end of the gene, and then for sure you've got all the important genes in between that are matched. On the other hand, if you have a related donor who's not a sibling, you always have to be worried that they're not necessarily a true match. And so almost everyone is really strongly pushing, and in fact protocols generally require full allele level typing of that particular donor to make absolutely sure that they're a match. And some programs, again, who are looking at DQB1 and DPB1 are also doing that as well. It is a standard, a well-established standard, that allele level typing needs to be done for all antigens that you care about. So for sure, at least 8. Almost every program in the country is doing 10. Again, with some programs also looking at the DPB1 alleles. For cord, this is evolving. In order for us to do a cord blood, many programs do cord when they can't adequately match others. Other sources, and so the nice thing about cord blood is it gives you more flexibility. Although it's an established standard to just do antigen typing for class 1 A and B, and then do allele level typing for class 2. Again, most programs now are doing allele level typing for all of these major antigens. So let's talk about these specific stem cell sources. This is important with your content. You need to know a little bit about each of these sources, how they're obtained, why they're obtained, and advantages and disadvantages of each one of them. We're not yet using these particular sources of stem cells, and there are actually other sources of stem cells that are being devised at this point through modification of genes and pushing cells into different lineages. But we'll focus on umbilical cord blood, bone marrow, and peripheral blood mononuclear cells or peripheral blood stem cells. PBSCs is usually seen more in the literature. Oops, went the wrong way. Apologize for that. So bone marrow, of course, is obtained by the traditional method of doing a bone marrow harvest. Patients are taken to the operating room, placed on their stomach, and a harvest is performed by harvesting from the posterior iliac crest. There's only one purpose for the posterior iliac crest, and that's to do bone marrow sampling and bone marrow harvesting. It's a really nice place. It has seriously it doesn't support anything. It doesn't have major muscles and ligaments connected to it. It's just there for a good reason. When people obtain peripheral blood stem cells, they are obtained through the process of apheresis. If you have finished your fellowship and have not seen an apheresis machine, you need to start over again. This is an apheresis machine, of course, and this will be hooked to the patient. Patients are primed either with GCSF or, in some cases, GM-CSF. It's important to understand what they're primed with. In very rare cases, for a regular donor, plerixafor is used, which can increase your number of CD34 cells. Plerixafor is used very frequently in patients who fail to mobilize with GCSF or GM-CSF in the autologous setting. This is a picture of a placenta that has been injected with dye, and so it can give you just a hint of what happens in order to obtain umbilical cord blood, either with the placenta still in the woman or just after delivery. The placenta can be taken and put into a situation after clamping where it can then be drained. These vessels are cannulated. The cord blood is harvested, and then it's characterized and stored. The cord blood units vary in volume tremendously, with some small units being as low as 50 cc's and larger units being over 100 cc's. What matters most with cord blood, of course, is content and how it's processed. We'll talk a little bit more about exactly the types of doses you need in order for cord blood to be successful. So the next question, again, for content is, what should you be using for what types of transplantation? It's very important for you to know the difference between an autologous and an allogeneic transplant. I think that's very straightforward. But when you do an autologous transplant, of course, what should you be using as far as your stem cell source? And the winner for sure is you're using peripheral blood stem cells for an autologous transplant. And why is that? Well, the reason why is it's very straightforward and much more likely that you'll get a very high dose of CD34 cells or for the procedure by having the GCSF mobilized as opposed to doing a bone marrow harvest. Because peripheral blood stem cells lead to very rapid recovery, that means you'll have a shorter inpatient stay, less chance of risk. Back when we used to manipulate and remove cancer cells, it was a lot easier to manipulate peripheral blood stem cells. We're not really manipulating this anymore, although it still is in your content, talking about when to do a purging of autologous stem cells. And I'll just say, as a quick, easy way to that, never. If it comes up that someone's still purging out there somewhere, then forgive me for making that statement. But bottom line is the real stem cell source that you use for autologous transplantation is peripheral blood stem cells. For allogeneic transplant, the story is very, very different. And again, I'll be telling you just a few more things about this. But there are advantages and disadvantages to umbilical cord, bone marrow, and peripheral blood stem cells. The advantage for umbilical cord is the availability to have less of a match and still be able to have acceptable rates of graft versus host disease and good outcome. Bone marrow is right in between. That's the baby bear porridge. Peripheral blood stem cells. The advantage of that is you get very rapid immune reconstitution, so less early transplant-related morbidity, but it leads to more chronic graft versus host disease, which can be a disadvantage. So there's no clear winner for allogeneic transplant for these sources, and centers will use each one of these sources, individualizing them to the needs of their patient and the priorities of the program. This is a very nice graph from the CIBMTR that just gives you a little bit of an idea of what is used. And as you can see here, everything is used in pediatrics. And this hasn't changed. This goes to till 2011, but this really hasn't changed. There's a real divide. As you can see, there's a little more blue than everything else. So pediatricians prefer to use bone marrow. It's safer, and there hasn't really been shown to be an advantage for peripheral blood stem cells, and in fact, there's likely a disadvantage in pediatrics. But bottom line is all of these sources are used in pediatrics, and so doing bone marrow transplant in pediatrics, you need to kind of be aware and ready for that. So talking about levels of matching, just to make this really crystal clear, whenever you see in the literature 6 of 6, it means A, B, and DRB1, and so on down the line. When you get to 8 of 8, you're adding C. When you're getting to 10, you're adding DQ. And when you're getting to 12, you're adding DP. So try to make sure that that's in your brain. And remember that these were the original ones. C was added, and C is just as important as A, B, or DRB1, but it took us about a decade or so to figure that out. DQ, slightly less of an effect, but still important, especially in the context of other mismatches with ABCDRB1. And DP hasn't really made a big difference in survival in most transplant studies, but it does make a difference in graft versus host disease, especially if there are different combinations of DP. You don't need to know all that detail, but you just do need to know what a 6 of 6, 8 of 8, or 10 of 10 mean. So very key considerations when you're trying to figure out HLA typing. And again, this is you're always going to get questions on the boards about what's the better donor. It's an easy thing to ask a question about, and it's one of the most important things that transplant physicians make their decisions. It's one of the most important decisions transplanters have to make. So the key consideration is this: HLA match trumps everything. In almost any situation, and I can think of only one exception, I'm not even going to tell you about it, in almost every situation, it is better to have a better HLA match in patients that receive allogeneic transplants. When you get a single, when you're talking about standard use of bone marrow or peripheral blood stem cells, and this particular level of mismatch, again, is the National Marrow Donor Program standard. It's not necessarily a center standard. Some centers prefer a 9 out of 10 match as what will be allowed. It's generally agreed and supported that when you go below a 7 of 8 match for standard transplantation, you start running into trouble, and you have to start treating those patients like a haploidentical match. With cord blood, 4 to 6 matches is what is considered a standard. It's almost, you can almost always find a cord blood with a 4 to 6 match. There's a nuance of this. When 4 to 6, using the old method where A and B is an antigen match, what you find is when you do allele level typing, that 4 to 6 match could be a 3 out of 8 at the allele level, because some of those antigens weren't allele matches. And that's been shown to have worse outcomes. So many programs now are really saying we're moving beyond looking at only 4 to 6. We'd like to do allele level typing, and we'd prefer to have a 6 to 7 or an 8 of 8 match, because those particular matches actually are better. There is some literature also suggesting that a very high cell dose will overcome mismatches. So when you're doing cord blood transplantation, it's not only match, a very high cell dose can help you have a better outcome. This is something that I mentioned a little bit earlier. I want to emphasize it again. Bone marrow is the preferred stem cell source in pediatrics over peripheral blood stem cells. The data is especially strong for non-malignant disorders. And if your patient is getting peripheral blood stem cells for a non-malignant disorder, you have to have a real good reason for that to happen. In other words, an approach to GVHD prophylaxis that mitigates graft versus host disease or T-cell depletion. Peripheral blood stem cells results in faster engraftment, but as I mentioned, more graft versus host disease. And for that reason, when patients receive reduced intensity approaches, it's often the choice will often be made to use peripheral blood stem cells. Reduced intensity regimens are used infrequently for cancer diagnoses in pediatrics, but they're used when patients have comorbidities or major problems that preclude them from getting a fully myeloablative regimen. And in those circumstances, many times you will want to use peripheral blood stem cells in order to enhance the graft versus leukemia effect. Screening for a donor is very important, and again, for sure, you'll get 1 or 2 questions on your test about screening. The donors that you'll be screening in the pediatric context are pediatric donors, and most of those pediatric donors will be under the age of 18 and therefore will need special handling. One thing that you need to do to be cognizant of the needs of a child that's not old enough to give true consent is the principles of assent. You need to make sure that the kids are buying into this. And you also need to be very careful about this. When parents have a child who's incredibly sick, and then they have another child who's not so sick but may have some health problems who can be a donor, those parents will probably look at the child with leukemia and say, your severe asthma is nowhere nearly as bad as the child with leukemia. And they might be very willing to have that child be a donor when it might not be medically appropriate. So you need to be very careful and understand that your parents are in a bind when they have to have competing needs for protecting the donor versus giving a good stem cell source for their very sick recipient child. There are a number of ethical challenges which we won't go into here, but the most important thing here to understand is that you need to avoid risks to donor health. Donors with underlying disorders or medical evaluations should be, of course, assessed by your team, but then also assessed by experts in order to get an opinion about whether going through the harvest procedure, which includes general anesthesia and a recovery period, would cause them problems. If there are issues that can lead to poor outcome, potentially in a donor that has underlying morbidities, that donor should not be used because there are lots of unrelated donors potentially out and available for that child, and you shouldn't harm a healthy sibling donor. Other considerations for donor choice, the age of assent and consent. If there is an absolute equivalence between a younger donor and an older donor, then choosing the adult donor who can give consent is appropriate. Now, understand that there are better outcomes the younger the donor is, and so if there are a lot of siblings in a family and you have an 18-year-old sibling who is almost identical to a 10 or an 8-year-old who's donating bone marrow, your transplant center may make the choice to use the younger donor. But if other things are equivalent, having a donor that is old enough to consent is appropriate. Blood type matching helps. And this is something to keep in mind. Again, part of your content is to know other considerations for donors. If a donor has the same blood type, it helps, but it's not necessary. You can use a donor with a differing blood type. CMV negative donors for negative recipients is quite important. The most important thing for CMV risk is the status of the recipient. If the CMV recipient, if the recipient has been exposed to CMV in the past and is CMV positive, then they are at CMV risk. Most programs are actually trying to do CMV positive donors to that CMV positive recipient so that they can have early immune recovery to CMV, but that's not absolutely necessary. The key to think about for the boards, again, is CMV negative donors to negative recipients is very important. A gender match could be important, but it's not absolutely necessary. The gender match of male to female is been shown to be reasonable Now with some of the latest data, most of the female-to-male transplants are fine as long as it's not a multiparous female. If a female has had pregnancies, then that's when the risk of graft versus host disease in the recipient increases. So parity is very important when looking at a female donor. One thing that you also need to consider is donor-recipient size mismatch, which can definitely be a problem. A general rule of thumb is that the maximum amount that you want to take from a donor is 20 mils per kilogram, and your goal should be try to aim for a dose of at least 3 and over 5 if you can, times 10 to the 6 CD34 cells per kilogram to a recipient. The cord dose, and again this points out a mistake in my first slide, is preferably greater than 3 times 10 to the 7th total nucleated cells per kilogram. You can use 2 doses to choose 2 cords in order to achieve this. When you have more mismatches, people prefer to go higher, as high as 4 or 5 at least, times 10 to the 7th TNC per kilo. Now, the reason why I put this particular slide in here was to really try to help you understand the general principle of T cells being vital to why the stem cell sources are different. What you can see here, and I'll just guide you through one of these, if you think it through, you can reason your way through almost any question you're going to come across on the test. So bottom line here is, we'll start with peripheral blood stem cells, and everything else lines up against those. Peripheral blood stem cells have very high T cell content. And in addition to that, they're going to have very high CD34 content. So they're going to have a rapid neutrophil recovery. In fact, some of them engraft as early as 8 days. They can engraft very quickly. They're going to have a very low risk of early post-transplant infections. It's going to be low to moderate. They're going to have a very low risk of graft rejection. They're going to have a rapid time to immune reconstitution. Their risk of acute graft versus host disease, in some studies it's higher, in other studies it's the same as bone marrow. But the big issue here with a very high T cell content is the risk of chronic graft versus host disease. So lining it up, bone marrow has moderate T cell content, so everything is adjusted according to that. Cord blood has low T cell content, so they're going to be slow to engraft. They're going to be slow to gain their ability to fight infections. They're going to have a higher risk of graft rejection, and their risk of chronic graft versus host disease is very low. The 2 things that are outliers here that, again, you need to fold into this is T-cell depleted bone marrow or peripheral blood stem cells look a lot more like a cord blood, and haploidentical T-cell depleted bone marrow or peripheral blood stem cells look a lot more like cord blood too, but are even slower in many cases for immune recovery. So these are the main variations. Again, the 3 stem cell sources that I told you about, with some variation where you take PBSCs mostly, or on occasion bone marrow, and you do T-cell depletion procedures. So if you kind of just keep in your mind, T-cell is the key, you can then kind of fold that into thinking about all of these different questions that may be part of the content that you'll have to be asked about. So here's an important thing here. This is 2 pictures, and you may or may not be able to figure out who are the twins that are syngeneic and who are the twins that are fraternal. It's actually these ones that are the fraternal, and these are the syngeneic ones. But when should you ever use a syngeneic donor? Let's assume that your fraternal twins here happen to be HLA matched. Remember, there's only a 1 in 4 chance that they're going to be HLA matched. And of course, your syngeneic twins are going to be HLA matched. When should you use a syngeneic donor? And the answer is almost never. If you're doing a transplant for genetic disease, of course, you're not going to use an identical twin. If you're doing a transplant for most of the diseases that you need allogeneic for leukemias, etc., you wouldn't use that. If you're doing an autologous transplant, you still wouldn't subject that syngeneic twin to GCSF and autologous collection, unless you had a darn good reason to do it. So almost never will you use a syngeneic twin. Okay. Other thing that you need to know, again, because there's a big emphasis on understanding when patients can and can't go to transplant based on pre-transplant morbidities. You need to remember that the very best circumstance in taking a patient to transplant is that they're healthy. They're in good shape. So bottom line, anything that impairs that is going to increase your risk for transplant. But let's get more specific about that. That is that patients who have active infections or inflammation, that will cause a much increased risk of furthering that inflammation with the already very inflammatory environment that happens when you get into a bone marrow transplant, especially an allogeneic transplant. It is also a big risk of non-recovery of counts pre-transplant. The reason for this is prolonged neutropenia. If you have a patient who gets an AML therapy, doesn't recover their counts, and you decide to do a transplant 5-6 weeks later, then the patient will have another 4 or 5 weeks of neutropenia, and that 2.5 months of neutropenia is going to add up to a huge infection risk for invasive fungus. So non-recovery of counts is a big deal. Just having a short period of count recovery really markedly decreases your risk of invasive fungal infection and other infections. Patients who are not in remission, of course, are not only at increased risk for relapse, but they are at an increased risk in most cases for transplant-related mortality, likely due to a number of different reasons. Even patients who are just MRD positive, of course, are at a markedly increased for relapse. So keep that in mind. Patients in great shape who seem to be in remission, if they're MRD positive, they have a marked increase in risk. If patients have underlying organ damage, and I always think of it as the big four: lungs, liver, heart, kidneys. Any one of those particular organs that have been damaged, that increases your risk for a poor outcome. Patients who have low performance status, it's been shown in study after study that if your patient can't stand up, then you're at a markedly increased risk during transplant, mainly because of risks of infection and other issues associated with immobility. Patients who have psychiatric disorders have been shown to have an increased risk of morbidity associated with transplant. Some of these particular issues can be addressed by using reduced intensity conditioning regimens, and that's actually what the whole field of reduced intensity conditioning regimens has been developed in order to address. This slide will hopefully give you a handle on a very important part of your content you need to understand. The difference between a reduced intensity regimen and a myeloablative regimen, and have a general idea about when you might want to use them. The principle here is non-myeloablative regimen. If you actually have that, by definition, you could get that, and if you weren't given a transplant, you'd recover, and you'd recover fairly quickly and do pretty well. If, on the other hand, you get your preparative regimen and don't get an infusion, and it's a reduced intensity regimen, you may not recover. Or if you do recover, it would take a very long time. With myeloablative regimens, however, almost assuredly, once you receive a myeloablative regimen, you never would recover. And there are some more specific definitions which you don't need to know in detail, but that's the general principle of reduced intensity and non-myeloablative regimens as opposed to myeloablative regimens. So, how should we decide, and this is important in your content too, you're generally asked to have a little bit of an understanding about what types of regimens you should use for various disorders. This has actually changed over just the last few months because there was a very large trial that was only in adults that looked at reduced intensity conditioning regimens versus a myeloablative regimen, and it showed a superior outcome for the myeloablative approach. Now, this hasn't been done in pediatrics, but in pediatrics it's generally been the practice. So a busulfan-based myeloablative regimen is generally considered the standard of care for AML. There is retrospective evidence that a TBI-based transplant approach gives a superior outcome in ALL. Now, it's interesting, the Europeans through the IBFM are doing a very large 1,000 patient randomized trial in order to address this. They are hoping to get rid of TBI, and there is some evidence with modern transplantation that we may be able to change that, but for now, most of the evidence suggests that for lymphoid malignancies, a TBI-based regimen is important. For non-malignant disorders, the preparative regimens vary, and it's too complicated to give you anything very specific about this. The most important thing to keep in mind is reduced intensity regimens for HLH are probably important because it's a very significant inflammatory disorder, but even this is somewhat disputed. Reduced intensity conditioning regimens are great, and we want to use them as much as we can, but sometimes it's very difficult to get a graft in, and so there's a lot of work in this area. We work very hard to give the least toxicity we can with non-malignant disorders, and some of them are easily done with reduced intensity and reduced toxicity regimens, whereas others do, unfortunately, still require myeloablative regimens. A key thing to keep in mind, of course, are these issues below, because you're supposed to understand for your content that some disorders require reduced, minimal, or no PrEP. Dr. Pai did a very good job of letting you know about SCID, where in the case of SIB donors, no PrEP is needed, and less PrEP may be needed for other types of SCID. Fanconi anemia patients, and this is, every other test you'll get a question specific about Fanconi anemia. They're very sensitive to preparative regimens, and the preparative regimens that Fanconi anemia patients can tolerate are about a third the intensity of what normal patients can tolerate because of their extreme sensitivity to both radiation and alkylators. These are a number of preparative regimens that go across this particular these definitions that I've mentioned to you: non-myeloablative, reduced intensity, and myeloablative. And all of these regimens are being used by pediatricians. As you can see here at the very top of the myeloablative, you have radiation-based TBI regimens with about 12 to 1400 centigrade of TBI, plus or minus a number of different chemo regimens, BuSci as a standard, and various variations of BuSci, busulfan, cyclophosphamide. Here you can see a border between reduced intensity and myeloablative, or what we call reduced toxicity regimens, combinations of busulfan with fludarabine or treosulfan with fludarabine. Further on down, the true reduced intensity regimens are fludarabine plus melphalan and lower dose busulfan or half dose busulfan plus fludarabine. The non-myeloablative regimens you can see listed here, either 200 centigrade TBI alone, a little bit of TBI plus fludarabine, Flu-Cy ATG. There are a few other regimens, Thiotefa fludarabine, that fit into that category as well. So this, again, is an important thing just to glance at and have an idea about the non-myeloablative, reduced intensity, and myeloablative regimens. Let's talk about this time during the transplant that Dr. Pai mentioned briefly. You have a patient, again, who's on day 9, has a high fever and a patchy infiltrate. What's going on there? I'm going to go through this pretty quickly because Dr. Pai did a great job of it, and you can refer to her slides for more details. Bottom line is pre-engraftment, very marked increase in risk of infections. This particular slide goes through a few more details. Again, I thought Dr. Pai's presentation of this was really nice, but you can refer to this as well to give you some clues about the early engraftment and later risks of infection, because again, that's part of an important part of the content. Prophylaxis, you should know a little bit about prophylaxis for your content as well. To prophylax for HSV, we do acyclovir. For CMV, some centers do ganciclovir, foscarnet preemptive therapy prior to the transplant, not necessarily during the transplant. And the most common thing that's done with that is to wait until patients have reactivation of CMV before treating with ganciclovir or foscarnet. Salvage therapy can be done with viral-specific T cells. For prophylaxis for fungus, almost all programs will use either fluconazole or voriconazole or other antifungals for prophylaxis for the first approximately 70 to 90 days after transplant. Echinocandins are often used as well. The only drug that's been approved for prophylaxis actually is posaconazole. But bottom line is fungal prophylaxis is incredibly important in transplantation. For PJP prophylaxis, that was mentioned already. It's very important. Usually transplant programs will have patients get a load of Septra prior to transplant and then restart it about day 30 after engraftment when they can tolerate it. Other meds that are used are shown here. As Dr. Pai mentioned, antibiotics are controversial. Some programs swear by it and insist on it, and others wait until the fever occurs before treating with antibiotics. Key infectious consideration are that the transplant approaches absolutely affect immune recovery, and this needs to be changed based on what you're doing. A number of centers are really focused on cord blood transplantation or on T-cell depletion, and those centers need to practice differently. They need to screen much more for CMV, adeno, EBV, HHV6. Because these infections occur a lot more in the setting of a T-cell depleted transplant. The other key consideration is that the occurrence of chronic graft versus host disease absolutely increases risk. So let's talk a little bit about acute graft versus host disease. This is a very important part of your content. It's usually diagnosed before day 100, but there's a definite description now of that's been actually going on for the last decade of patients who get peripheral blood stem cells who can get a late form, especially if they've had a reduced intensity regimen, that can generally go out to about day 200. It can occur near the time of engraftment. In fact, in myeloablative settings, about more than 90% of it occurs before day 50. It almost always involves the skin, but it can, of course, involve the intestine and liver. Very early lung idiopathic pneumonia syndrome may or may not be associated directly with GVHD disease, but you can have an early GVH-like phenomenon with the lung, and it's a very substantial cause of morbidity and mortality. This is a picture of a rash on the hand, the typical truncal rash. This is a picture of what you see, basal keratinic apoptosis. Apoptosis is the word you need to remember, both for looking at intestinal and looking for skin. Significant apoptosis is one way that your pathologist can have a better insight into whether your patient has graft versus host disease or not. This is acute graft versus host disease staging. This may be changing over time as we get better at looking at biomarkers, but this is what we have for now. The key here is that you've got skin, liver, and gut. The gut is dependent upon diarrhea volume. The liver is dependent on bilirubin, and the skin is dependent on rash. An important thing down here is lots of rash, high bili, lots of diarrhea. That doesn't get you to grade 4 here. What you get for grade 4 is severe abdominal pain with gut, generalized erythema with bullae that covers at least 5% of the body surface area for skin. So again, you got to have a bullous rash in order to get to grade 4 for skin. Bilirubin greater than 15, but you need to make sure it's not veno-occlusive disease. Grading is different than the staging, and a key here to remember about grading is there's no such thing as grade 1 that is anything more than skin. A tiny bit of skin is overall grade 1. You can have stage 3 skin and it's only grade 2 as long as you don't have more than grade 1 liver or gut. And everything higher than that is grade 3. And I told you have to have those extra oddball things in order to get your patient to a grade 4 graft versus host disease. So GVHD prophylaxis, most centers use calcineurin inhibitors with methotrexate or mycophenolate mofetil. There are a number of other combinations that are available that include use of sirolimus, ATG, post-transplant cyclophosphamide, or T-cell depletion. Complete removal of the T cells, of course, through T cell depletion is problematic because it leads to excess infection, rejection, or relapse, but oftentimes you can work out a way to do that successfully, especially for non-malignant disorders. Primary acute GVHD therapy is important in the content. What essentially happens, and the key thing to remember, is if you have mild disease that is limited to skin alone, very few people will do anything other than maybe optimizing their TACR or cyclosporin levels and using topical steroids. If your skin then progresses and you have multisystem, then most centers will start with prednisone. Prednisone, if you do not respond to it within 3 to 7 days, then you have what's called steroid refractory chronic acute graft-versus-host disease. There are a number of different things that are being proposed to treat this. There's no really well-established standard of care, but remember that kind of general approach. Here's a case scenario. You have a child who presents late. Some key things in here: dry, irritated eyes, persistent cough, and he doesn't have fever. So what are you going to do to diagnose him? And here your answer is you're going to do pulmonary function tests and high-resolution CT. This really isn't looking like an infection, although one might consider sending some of these other things. This is a classic presentation of chronic graft-versus-host disease. So it's generally diagnosed after day 100, although it can occur earlier. There are a number of different classic things you see with it: skin with lichen planus or poikiloderma. You can have scleroderma associated with it. You have dry eyes, dry mouth, so the Sika syndrome. If you have chronic liver insufficiency and are unsure what it is, you can get a biopsy and show this phenomenon of vanishing bile ducts. Pulmonary, there's classic ways of looking at this with CT scan to diagnose bronchiolitis obliterans. And of course, it's associated in the GI tract with strictures, fat malabsorption, and other issues. These are some pictures of some sclerotic lesions. You can oftentimes have skin coloring changes. This is hand lesions of sclerosis and poikiloderma, which can occur in patients with chronic GVHD as well. So you're supposed to know for your content the risk factors associated with chronic graft-versus-host disease. This is going to be some general risk factors and other information about it. One important thing to keep in mind is this is from when the GVHD occurred, which could be, from about month 3 to month 18, or even later in some cases. So this is actually several years after transplant that they're getting onto this line in some cases. The majority of patients of pediatric patients who get chronic GVHD can get off immune suppression, and usually they get off it within the first 24 months of when they have it. If they're not off of it at 24 months, unfortunately, many of them need to have immune suppression for an extended period of time. A lot of these patients are on mild or minimal amounts of immune suppression, but some are on significant amounts of immune suppression. So even at 5 years, you can have persistence of patients on immune suppression. Key risk factors: patients who are younger are less likely to have fatality from chronic GVHD. Patients with advanced disease are more likely to have fatality. Low Karnofsky and platelet count less than 100 is an important risk factor in understanding long-term outcome. Now, risk factors to get chronic graft-versus-host disease, the biggest risk factor by far is the use of peripheral blood stem cells and mismatch. So those are two very straightforward risk factors for you to keep in mind. Standard therapy is prednisone. It's something that we hate to give because it then needs to be on for a long period of time, but it's necessary to control a lot of chronic graft-versus-host disease. And then the key is there are many other agents you can use in order to get your prednisone dose down. The tapering needs to be incredibly slow, and as mentioned, median duration of treatment is 2 years for responding patients. This is a list of a number of different agents that are used as treatment for chronic graft-versus-host disease. Another case scenario for you. You have a 10-year-old who got a T-depleted transplant, and he presents with significant cervical lymphadenopathy and splenomegaly. most likely diagnosis is, and we're going for PTLD here. So let's talk a little bit about post-transplant lymphoproliferative disorder. This occurs within a few months after transplant, and it's highly associated with T-cell depletion. So keep in mind there are different techniques for T-cell depletion. The worst for this, of course, is CD34 selection because it causes very extreme T-cell depletion. There are others, though, ATG use or serotherapy, ATG or Campath, and this done in the not just with T-cell depletion, but also with cord blood can lead to PTLD. We follow patients now with EBV serology, EBV titers tested in the blood, and doing that we can actually see EBV titers rise and treat as appropriate with rituximab and keep these under control. Other therapy that you can give, of course, for that includes cyclophosphamide or CTLs, EBV-specific cytotoxic lymphocytes. Let's talk a little bit about veno-occlusive disease. It typically occurs in the first 14 days of transplant, although it can go up through day 30. Recently, with busulfan melphalan-based regimens for neuroblastoma, there have been even later onset VOD that has occurred with that particular regimen. When I say 25% of patients affected here, what that really means is that there's a lot of mild VOD. Severe VOD incidence is somewhere between 5 and 15%, depending on the approaches used. It's caused by endothelial damage to the hepatic venules, platelet deposition, hepatic congestion, and cholestasis. The key associations are cyclophosphamide and busulfan, especially when they're given together in TBI. Sirolimus used also as a post-transplant GVH prophylaxis has been associated with veno-occlusive disease as well. So here are the classic signs and symptoms: right upper quadrant pain, hyperbilirubinemia, weight gain. This is the diagnostic triad. These other things just occur, and it's an important thing to keep in mind. The definitive way to one supportive thing you can do, of course, is do a liver ultrasound and look for reversal of flow in the portal system. Management is generally a very tight fluid management to make sure patients don't become massively fluid overloaded and have organ compression. You need to maintain their intravascular volume, but also manage the fact that many of them can have organ failure. Defibrotide has been now FDA approved and is being promoted to all of your centers in great detail, I'm sure. It has been shown to have effect for patients who have significant veno-occlusive disease. Let's talk a little bit about thrombotic microangiopathy. This is also part of your content. This occurs, of course, when patients have endothelial damage that is caused from a number of different things. These patients, again, have hemolytic anemia, platelet consumption. It can be diagnosed by biopsy if you choose, but generally it's clinically diagnosed. And the kidney is most commonly affected, but we're actually seeing thrombotic microangiopathy now occurring in the lung and occurring in the GI tract. What you're looking for here is, again, thrombocytopenia, schistocytes on blood smear, and elevated LDH. It's definitely been associated with calcineurin inhibitors with both cyclosporin and tacrolimus. The combination of tacrolimus with sirolimus was shown to have a marked increase in thrombotic microangiopathy that can be mitigated when you take the sirolimus away. There's early evidence that eculizumab or a terminal complement inhibitor can improve renal function and salvage many of these kids that had very poor outcomes previously. Here's another question. We've got a patient who's 64 days out from a TBI-based transplant. He shows up in the ER. He's confused. He had a seizure. He has trouble seeing. You really need to know just one thing, and that is, what is his blood pressure? This is, of course, is PRES, or posterior reversible encephalopathic syndrome, and you can see white matter changes occurring in the cerebellum. This presents generally from day 30 to 100, although it can occur earlier. It causes headache, confusion, seizures, and visual loss. The most important thing is getting the blood pressure under control, and even more important than that is keeping the blood pressure under control and avoiding PRES altogether. This is definitely linked to the use of calcineurin inhibitors. And one thing to keep in mind is if you don't see it on CT imaging, MRI can oftentimes pick it up. But your clinical scenario usually is very important in making this diagnosis. There are a number of late issues after transplant that we're supposed to mention as an important thing for content. One thing I want to do to keep this in context is the most important issue that causes significant morbidity after transplant is still relapse, even if you take patients from 2 years after transplant. Although the vast majority of relapses occur in the first 2 years, when you look from 2 years beyond, there still are a small percentage of patients relapsing. Second malignancies occur in 2 to 6%, but increase over time, especially if you look very closely at some solid tumors, many of which are relatively benign. But bottom line is bad things can happen in about 2 to 6% of patients with AML, MDS occurring within the first 5 to 6 years usually, and not occurring as much long-term, but solid tumors occurring more long-term. There's a marked increase in Fanconi anemia patients. There's an increase in patients who've had to have radiotherapy as part of their transplant. Growth failure can occur as well in transplant. Some people think that every patient getting a transplant has growth failure, but that's not true. It's been very much associated with cranial irradiation, and it definitely can occur. When it does occur, it's usually addressed by use of growth hormone. Hypothyroidism, gonadal failure are some of the endocrine issues that can occur after transplant. Gonadal failure in myeloablative regimens occurs almost universally. Hypothyroidism can occur in somewhere between 25 and 35% of patients, depending on the preparative regimen they've had and any previous radiation that they might have had to the neck area. The main, one of the most important associations with late effects after transplant is if patients have had long-standing chronic graft versus host disease. Those are the patients who, when you look really carefully, tend to have the most long-term problems. Interestingly, cardiac effects post-transplant are usually related to either pre-transplant anthracycline exposure or radiation that has occurred either pre-transplant or during transplant to the cardiac silhouette. And graft versus host disease, of course, has been very definitely associated with long-term effects in the lung. There's some emerging evidence that TBI has a significant effect on children less than age 3 at transplant, but it's incredibly debated. But keep that in mind as something that might come up as a possible thing to worry about. Now, last time I gave this talk, I did just a marathon race through indications, and it made people so dizzy that what I'm going to do now is not torture you so much. I do have all the slides there for you to take a look at, but I think you want to keep in mind, as far as indications for transplant, that there are 3 things to keep in mind. One is cancer treatment. It does 2 things. It allows you to treat very intensely, and it allows you to have an immunological platform for graft versus leukemia or graft versus tumor effect. So cancer treatment is definitely an important thing for transplant. It can either replace or reset a dysfunctional hematopoietic or immune system. It's a great thing to use to treat patients who have sickle cell disease or other disorders of inherited disorders that are just of the marrow. We can completely eradicate that with transplantation, and of course we can fix the immune system. And finally, it's gene therapy. This is only for very specific diseases where if you deliver hematopoietic cells, you can actually significantly either decrease the symptoms associated with the genetic illness or even cure it in some cases. So that's the general and most important indications. The auto versus allo, the general principle for you is do an auto whenever you can, because it's safer, but that's relatively limited, and it's generally only patients in the pediatric setting with brain tumors, with neuroblastoma, with germ cell tumors that have very, very clear evidence that autologous transplantation is a benefit to them. I didn't mention some lymphomas as well, including Hodgkin disease. For the rest of them, they definitely need an allogeneic effect, and so we have to put them to the higher risk in order to help them out. Now, this particular slide is again addressing some of the content. What do things die from? What do people die from after transplant? You can take a quick look at that. These are generally. This is an overview of indications, which you can take a peek at. This talks specifically about ALL. Warning, you're going to get some ALL overlap. We had decided that the way that we would approach this is to try to have people who give your ALL talk give you a clue about when they want their ALL patients transplant. This is a bit of a moving target. These are outcomes that are well published that you can take a look at. Same with AML. Here are AML indications that you might have heard some of this in your AML content as well. Indications for CML, MDS, and JMML. Indications for lymphoma. Survival after lymphoma with CIBMTR data that I hope you'll find useful. There are some indications here for solid tumors with neuroblastoma brain tumors. The other tumors here at the bottom that I include, there's a lot of debate and controversy about when these particular tumors should be transplanted. Germ cell tumors have more evidence that it's a benefit. I won't go into that controversy very much, but just to let you know what people are thinking about. There are a lot of indications for non-malignant disorders. Dr. Pai went into great detail about the immune deficiencies, and that was much appreciated. But remember that, of course, bone marrow failure or lineage insufficiencies can definitely be treated with transplant as well. This is aplastic anemia, one of my favorite diseases for transplant because they do so well. One thing also, again, here are a number of indications for transplantation where it's used as a form of gene therapy, imperfect as it is as a gene therapy for these particular diseases. So, one thing I wanted to do is make a pitch that it's not in the content yet, but the future of transplant is targeted cellular therapies. I would love to be only doing transplantation for non-malignant disorders because we figured out how to treat everybody with cells that are a little bit smarter than the regular allogeneic cells that we give. But that's a bit down the road and won't help you for your test. So focus on what we have reviewed right now, but realize that that's coming in the future. Cells can cure cancer. Thank you very much. I hope you found this useful. And again, please feel free to ask me questions.